Hey folks, Scott Weingart here for the MCRIT podcast. I promised you part 2 of the ventilator lecture, and I always keep my promises. So here you go. All right, so part 2 of not the best ventilator talk ever. And so this is how to dominate the ventilator. Last week we told you there's basically only 2 strategies you need to manage the ventilator in an emergency department patient. There's the injury strategy and the obstruction strategy. If the patient has an obstructive lung disease, like asthma or COPD, then that's the strategy you use. Otherwise, for everyone else, use the injury strategy. Now, that's if they have a lung injury, like pneumonia, ARDS, pulmonary edema, or if they're prone to a lung injury, which is pretty much everyone else. Because if you do bad ventilator management on a patient with perfectly healthy lungs, they will start to develop lung injury. And we said last week the injury strategy essentially is the ARDSNet ventilatory strategy. You put them on assist control, volume mode, and then there's only essentially 4 dials you need to spin. Tidal volume starts at 8 mLs per kg, and if you find your plateau pressures are high, you dial down the tidal volume because tidal volume equals lung protection. Inspiratory flow rate is how quickly the breath is delivered. That's predicated on patient comfort. That's what that dial controls. If the patient looks like they want more air at the beginning of the breath, then you just dial up the inspiratory flow rate from about 60 to start to anywhere from 80 to 100 if they need more. Respiratory rate. Start at 16 to 18 because we're using lower tidal volumes. Titrate up and down based on the CO2. The respiratory rate dial equals ventilation. Last but not least, the FiO2 and PEEP dial. Think about them as one even though they're 2 separate settings. You start the FiO2 up at 100, after 5 minutes drop it down to 40, and then you titrate the PEEP and FiO2 in tandem using the PEEP table. Why the PEEP table? Because it forces you to go up on PEEP, which is what's going to keep those alveoli open and from having collapse, atelectasis, and atelectotrauma. Instead of being able to dial up the FiO2 to 100 and leave the PEEP down at 4, this forces you to do the right thing and keep those alveoli open. So you start off at 40% FiO2, 5 of PEEP, and you work your way up in tandem. All right, so that is the injury pattern. Just a quick review. Hopefully that will prevent the gummy bear from dying from bad ventilator management. But what we're talking about today is the obstructive strategy. It's for your asthmatic patients, your COPD patients. And if you had to ask yourself, what is my goal? What is the one goal for this ventilatory strategy? The goal is give the patient time to expire. All right, let's say that one more time. The goal of the obstructive ventilatory strategy is to give the patient time to breathe out. That's it. And if you keep that foremost in your mind, you're going to do the right thing. So what's your mode? Your mode is assist control, volume, just like normal. Most common standard mode in North American EDs. I assume the rest of the world as well. Don't mess with it. There's plenty of really interesting modes. There's plenty of modes I use on an everyday basis. You don't need them. They're only theoretically of benefit compared to this. Stick with assist control volume unless you know what you're doing. All right, first dial is the tidal volume dial. This one's easy. You just put it at 8 mLs per kg, ideal body weight, and chances are you could just leave it there. These patients should not have issues with needing lower tidal volumes. Just stick with the 8 mLs per kg, you're golden. And that means ideal body weight predicted based on the patient's height. You don't need a chart, just take a quick look. If they're 5'1", I don't care if they're 700 pounds or 100 pounds, chances are they're about 50 kilos. Inspiratory flow rate. Now, we said earlier that this is a comfort setting for the injury patients. For this, it kind of helps us get towards our goal a little bit. Our goal being give the patient time to breathe out. Because if we make the inspiration time shorter, then it makes the expiration time longer. So you might want to set this a little higher. Generally, I'll start at 80 to 100 liters per minute. Thing is, when you actually calculate this out, when you actually look at the mathematics, it really doesn't make a whole bunch of difference. So if you forget to adjust this dial, I always tell people if they have to forget about one dial, forget about the flow rate dial, and nothing bad will happen. If this got set to 60 on these asthmatics or COPDers, no real change. The amount of difference it makes is almost negligible. All right, the FiO2 and PEEP dial. These are easy as well. FiO2, you set them at whatever you need to get a saturation greater than 90%. But there's no reason these folks should have oxygenation issues. In fact, when you see an asthmatic desaturating, it's because they're so far gone, they're not even taking any tidal volume anymore. It might look like they are because they're still moving their chest, but they're taking those little dog pant respirations by the time they're desaturating. They're not really doing any gas exchange in their alveoli, and that's why they desaturate. Well, if they're intubated, that's not going to be the issue. They're not going to need much oxygen. But give them whatever it takes. I don't care. I'm not going to be pedantic about this. If you want to leave them up at 80%, knock yourself out. But there should be no call for it. Generally, I'll just take these guys, and after 5 minutes on 100, knock them down to 40, and you can leave them there the whole time. They don't have oxygenation problems. Asthma, COPD, it's generally a disease of ventilatory failure. It's a type 2 respiratory failure if you want to get into the critical care stuff. Type 1 is an oxygenation problem, type 2 is a ventilation problem, and these folks are type 2. All right, PEEP. I tell you, for the purpose of this talk, just set the PEEP to 0. In the pulmonary critical care world, we call that ZEEP, Z as in zebra, EEP, which stands for zero end expiratory pressure. And you can make a lot of theoretical arguments about why a little PEEP would be a good thing on these patients. And you could talk about stenting open the bronchioles. And there's a lot of crap you could spew. And I have been right up there spewing crap about this stuff. And I can make, if you wanted to put me on the pro side for giving a little PEEP in these patients, I can make some cogent arguments. Guess what? When it really comes down to what makes a difference, PEEP is not the answer in these folks. You could do a lot of damage with a poorly set PEEP in these folks. I say just make your life easier and put it on 0. Now, you'll get some arguments from people, and you just tell them, talk to Weingart, and I'll be happy to defend the 0 PEEP. I could argue that really well as well. And you're not going to cause any damage by putting these patients on 0 of PEEP, and that's the key. So that's what I tell you, is just put them on 0. If it makes you happy to put them on 2, 3, 4 of PEEP, that's fine too. You're not going to probably cause much problem. If you get beyond that, you're risking screwing things up. I'd say it's not worth it. Respiratory rate. This is the one that matters. This is the most important setting for an obstructive patient. You could arguably say in the injury patient, it's the tidal volume dial. For these patients, it's the respiratory rate dial. And just like tidal volume was how to protect the lungs in an injury patient, respiratory rate is how to protect the lungs in an obstruction patient. You want to set this low, and I'll explain why in just a second. So I tell you to start off with 10 breaths per minute, which is way too little to achieve eucapnia. That's okay. Start at 10, and you can adjust up or down depending on how the patient's lungs are doing. What you're looking for is an I to E ratio, an inspiration time to expiration time ratio of 1 to 4 or 1 to 5. Normally, these patients are breathing at 1 to 2 or 1 to 3, which means for every second they spend in inspiration, they spend about 2 to 3 seconds in expiration. You want at least 4 to 5 seconds of expiration in these patients. You want to give them a long time to expire. The pathophysiology of asthma or COPD is that they can usually get air in until their respiratory muscles are really tired, but they can't get it out because there's those bronchial obstructions. So they get air in, they can't get it out. That leads to their lungs being overinflated, and if you keep popping air on top of that, that's where you lead to problems like pneumothorax and barotrauma. So if your ventilator has the ability for you to see an I to E ratio, this is what you want to see. Greater than that is fine. Less than that, probably not so much. All right. You got to understand these patients are going to be hypercapnic. That's part of this respiratory strategy. They're not going to have a CO2 of 40. Their CO2s might be 50, 60, 70, 80, 90. That's okay. They'll tolerate it. It's fine. As long as their pH stays above 7.0 to 7.1, they're doing golden. And really in the ED, there's no reason that they should need to go below that. So titrate them to the point where that's generally where their pH is. Now, some people would start bicarb drips at those levels. I don't think from the pathophysiologic point that makes much sense. Bicarb gets rid of acid by generating CO2, and the reason these patients are acidotic is because of CO2. It doesn't really work for me, and they don't need it. There's been a number of studies. Patients tolerate extremely well down to about 7.1. All right, all this stuff is predicated on avoiding air trapping and AutoPEEP. And essentially what happens is, if you don't give these patients enough time to breathe out, they'll keep stacking their breaths on top of each other until their lungs are so overinflated they pop. All right. Now, these terms are slightly different. Air trapping generally refers to alveoli that are just closed off because of mucus plugging and air can't get out. They need pulmonary toilet. They need good suctioning to fix that. And AutoPEEP is the more dynamic overinflation of the alveoli that if you let them breathe out entirely would go away. Now, how do you know if you're dealing with these problems? How do you know if your respiratory rate needs to be dropped even further? Well, the best way is if your ventilator could show you a flow waveform, which looks like this, then you'd have the ability to actually see this. And let's see. Now, the dotted line is the normal expiratory pattern. What happens is you get a breath in, that's that inspiration side in red, and then the patient breathes out, and eventually they hit this zero line where there's no more flow. And that means they've expired as completely as they could. And you can see they hit that zero line, and then there's some time before the next breath. And that shows that they've completed their expiration before their next inspiration. All right, now look at the solid blue and solid red line. They get that same inspiration, and now they come down here to that solid blue line, and they're expiring, they're expiring, they're expiring, and you see they haven't hit zero yet, and the next breath comes. That means they still had air in their lungs, and then the ventilator breathes in again, and then they want to expire. Each breath at that point is going to put more and more air that can't get out. Breaths are going to keep stacking on each other. Eventually, the patient's alveoli are going to be overfilled, and they're going to have real problems. All right. So if you saw that waveform where they weren't hitting the zero line before the next breath, then you go down on the respiratory rate. Let's say your ventilator doesn't have waveforms. It's one of, let's say, the old bird vents that doesn't have that. Can you figure out if they're still having these AutoPEEP problems? Sure, you can look at the pressures. But the peak pressure, the pressure you get automatically on the ventilator, means nothing. Peak pressure means nothing. Peak pressure is the representation of the endotracheal tube and the large airways, like the bronchi and the bronchioles. They are going to be constricted in this disease, and therefore the peak pressure is going to be very high. It's going to be crazy high. It could be 70, 80, 90. And the ventilator is going to be alarming like mad unless you up those limits. The peak pressure tells you nothing about what's going on in the patient's lungs. On the asthmatics, I always raise that pressure alarm setting way high because I don't want to hear the vent alarming for this because it's not telling me anything. So if your peak pressure means nothing, what does mean something? Well, your plateau pressure, just like in the lung injury patient. So what you have to do is you have to do that same inspiratory hold we talked about in the last lecture. You have to have your respiratory therapist teach you how to get a plateau pressure on your ventilator, and you have to measure it. And if the plateau pressure is less than 30, then they don't have significantly worrisome AutoPEEP. If it's greater than 30, in these patients, the only reason for that is AutoPEEP, and you need to go down on the respiratory rate. All right, so measure your plat every 20 minutes or so. If it's less than 30, they're doing okay. Do they have some AutoPEEP? Sure, but not the point where their lungs are going to get injured. That's the key. All right, can you measure AutoPEEP directly? Yeah, there's ways. You could do an expiratory hold with the patient at zero PEEP. Not worth it. Don't bother. You don't care about that. You care about the effects of whatever AutoPEEP they have on their alveoli. Plateau pressure or that flow waveform is the much better way to go. All right, let's talk scenario now. Get a patient, you intubated them, they were a horrible asthmatic, you tried them on non-invasive, it didn't work, and now they're intubated, you put them on a good obstructive lung strategy, you're happy with yourself, you go see another patient. Come back, the nurse is rushing to you, grabbing you, saying the patient now has a blood pressure of 40/20, ventilator's alarming, saturation's down to 65%. What is going to be your first action? There's a ton of things you can do here, but what is going to be your first action? And if you say your first action is listen to lung sounds, wrong. If your first action is to grab the ultrasound and check for pneumothorax, wrong. If your first action is to play with the ventilator and adjust any of the settings, wrong. It's all wrong. There's only one thing you do in this situation. Asthmatic crashing on the vent. Only one thing. That one thing is you disconnect the ventilator circuit from the endotracheal tube. Don't do anything else first. Just go over and disconnect them from the vent. Leave them with a bare endotracheal tube. Now, if the problem was someone had messed with your ventilatory settings, and then that patient now has AutoPEEP up the yin-yang, they could actually have a cardiac arrest from that. The interthoracic pressure gets so high, they actually get no venous return, their heart could stop. Or they could just be looking like they're getting to that point, low sat, low blood pressure. If you disconnect them from the ventilator, and this is what's going on, what you're going to hear is a rush of air coming out of that endotracheal tube as they finally expire all that pent-up volume. And all of a sudden, they'll go from horrible hemodynamics and saturation to perfect, and you'll save a life. If you ever have a cardiac arrest in a ventilated asthmatic, first move, disconnect the vent. You won't cause any problems, the endotracheal tube open to air. Now, if they don't have that X-flow of air, then you got to start working up the other stuff. And then you start listening for pneumothorax. You grab your ultrasound, see if there's a pneumothorax. You make sure there's no mucus plug in your endotracheal tube by putting a suction cath down. You make sure there's still end-tidal CO2. Make sure that tube didn't get displaced. If you're really scared, you actually go in there with your laryngoscope, make sure it's through the cords. If it is, and you've ruled out pneumothorax, sometimes I'll actually change out these tubes because you'll have a big mucus plug that will let a suction catheter pass, but will have a ball valve effect. As soon as the suction catheter moves, it reoccludes the tube. So I have done that on occasion. But your first move is always, always, always disconnecting the ventilator from the ET. All right, we're running out of time. Just want to make a few more points. Big mistake people make is they had these patients on continuous nebulizers. They gave them steroids, magnesium. They decide non-invasive wasn't working. Always try non-invasive first in these lung obstruction patients. 99 times out of 100, they won't need to be intubated. But then you decide they do need intubation. So you intubate them, and everything looks well because the patient's sedated, they're satting okay because it's not an oxygenation problem. And then people forget to continue the nebulizers. Sticking an endotracheal tube in an asthmatic or COPD has done nothing to solve their problems. Really, you haven't addressed a whit of their underlying pathophysiology because all the problems are deep down in their lungs and all you've done is fix their upper airway, which wasn't really a problem in the first place. Sure, you've addressed their respiratory muscle fatigue, and that's really the only reason they intubate these patients, but you haven't addressed their bronchoconstriction. So continue nebs on the ventilator. If you don't know how to do that yourself, call respiratory and make them set up continuous nebulization throughout this patient's early ventilatory course. When they get up to the ICU, you can switch them over to metered dose inhalers on an intermittent schedule. In the ED, keep up near continuous nebulization for the first hour or two. And then last but not least, sedation. The reason you intubated these patients is because of respiratory muscle fatigue. There's really no other good reason to do it. So you don't want them spontaneously breathing. On all my other lung injury patients, I keep them spontaneously breathing. On my bad asthmatics or COPDers, when I first intubate them, I want them to rest up. I want them to get rid of that lactic acidosis from their respiratory muscles. So I sedate them like mad. And probably the best agent for this is propofol. First of all, it has bronchodilatory effects. And it also is really potent sedative agent. So that's my recommendation. But you want these guys schlogged. You want them not spontaneously breathing. You want them nice and relaxed, deep down on their sedation scale. You want a strong opioid to keep their pain, but more importantly, to keep them happy with the permissive hypercapnia. They're going to be miserable. Your sedation needs are going to be dramatically higher if you don't blunt the hypercapnic reaction. So give them high-dose fentanyl or morphine. Give them a propofol sedation package. Leave them schlogged until they get up to the ICU. All right. Send me any questions you have about any of this stuff. I'm happy to answer them either on the show or by email. And just to review, for the obstructive pattern, mode is assist control volume, 8 cc's per kg, ideal body weight on tidal volume. Inspiratory flow rate, if you remember, set it a little higher, 80 to 100 liters per minute. Doesn't make a big difference if you forget about it. FiO2 and PEEP. FiO2, set whatever you need to get that nice saturation, greater than 90%. Shouldn't need much. PEEP, I recommend 0. If you're going to do it at all, do very low levels. Most important dials, respiratory rate, start at 10. Either check your flow waveform or your plateau pressure. If either of those look screwed up, go down on your respiratory rate. All you need to oxygenate a patient, which is what you really care about during this period of time, is just a couple breaths a minute. So if you have to knock them down to 8 or 6, it's okay. Remember, continuous nebulizers and a good sedation package. All right, that's all. I'll have some more stuff for you next week. I'll talk to you soon. This is Scott Weingart for the MCRIT podcast. Bye-bye.